Hello and welcome all of you and welcome to this new session. Today we are going to discuss MCQs on the topic of abdomen. I'm Dr. Ankit, your anatomy educator in our Unacademy platform. Let us see some slides before we proceed. This is the NEET PG Vitals, and then we have this last week marathon, and we have the FMG series starting from the first week of Feb, and we have this subscription. You can use the code if you wish to. The code you can use is Dr. Ankit 10 numeric 10, right? Let us see is now some abdomen MCQs, and here's the first MCQ for all of us. The rotation of the stomach during development results in movement of the left vagus nerve from its original position. That's the statement. Question is that through approximately how many degrees of rotation does the nerve move? Which nerve? Left vagus. And what is its final position? Okay, so let us see how to proceed with this. We all know stomach and esophagus are a part of the foregut. This esophagus, and then we have this as the, imagine this is the stomach and the initial part of the duodenum. Initially they are around the esophagus. We have right and left vagus, but suddenly when you read in the stomach, they become anterior posterior vagal trunks. So how does that happen? During the rotation of the midgut, when there is 270-degree rotation of the midgut anticlockwise, the duodenum is being pulled to the right side, and therefore there is a 90-degree rotation of the whole foregut towards the right side. Suppose like this is the foregut, it moves like this, 90-degree towards my right. Therefore what happens is that this nerve, which was initially the left vagus, which they are asking in the question, it comes anteriorly in the stomach, while this nerve, which is the right vagus nerve, it will actually move behind posteriorly. These are the anterior posterior vagal trunks. So the left vagus nerve goes anteriorly, the right vagus nerve will go posteriorly. Now if we look at the options, they are asking about the left vagus nerve, so it becomes anterior vagal by moving 90 degrees. Therefore answer is option number, first option, answer A, option number A, right? This is the question number, first question. Let us see more questions. 22-year-old lady is admitted with severe abdominal pain, nausea and vomiting. Typical features. History taking shows that the pain is acute and has been constant for 3 days. Pain began in the epigastric and radiated bilaterally around the chest to just below the scapula. So there was radiating pain, which pain radiated, started at epigastric, it went below the scapula, all around, went behind. Currently the pain is localized in the right hypochondrium. CT revealed stones in gallbladder, that too calcified. So it's a case of cholelithiasis. Which nerve is carrying the afferent fibers of the referred pain? Now they're asking you, referred pain is carried by which nerve? We saw that the pain was in the epigastric, the right hypochondrium went behind below the scapula. They're asking you which nerve carries the pain. So what's the answer over here? Options you can see: greater splanchnic, dorsal prime rami, phrenic and vagus nerve. So over here, how to proceed with the answer? See, we all know that the visceral afferent, see, the diagnosis we all know is a GV stone. GV stone is the diagnosis. So it's a viscera. So the visceral afferents are carried by what? They are carried by the sympathetic nerves. Basic thing. Now which sympathetic will supply the GV? Gallbladder. Gallbladder is a part of fore, mid or hindgut. Coming from the hepatic bud, it's a part of foregut. So what is the sympathetic of the foregut? It is T5 to T9. So this which nerve? Greater splanchnic nerve. Greater splanchnic nerve. And if you look at the location of the referred pain, that is behind and below, just below the scapula. So if you look at the scapula also from the posterior aspect, these are the, imagine the two scapulas. At this level, it is around T8, T9, and that falls under the range, that falls under the range of this greater splanchnic nerve, right? So it is under the range of greater splanchnic nerve, which theoretically is also carrying the afferents from the foregut, that is the gallbladder. Therefore, in this question, this is the answer over here, option number A. Dorsal primary rami will only innervate a very small part of the body, that too in the posterior aspect around the vertebrae. Phrenic and vagus nerve nothing to do with GV stones. Plus, phrenic nerve may at times, if the disease from the gallbladder went to the upper surface of the liver, it may irritate the diaphragmatic peritoneum, where the phrenic nerve can be irritated. Even then, if the phrenic nerve is getting irritated, the root value of phrenic nerve is C345. Referred pain won't go to behind below the scapula, it will go at the tip of shoulder. Because there is a supraclavicular nerves C345, same root value phrenic nerve C345, that is the location of referred pain, not behind below the scapula. Okay, so answer is option A. I hope it clarifies. Let us see a couple of more. 34-year-old is admitted to the emergency with groin pain. Okay. Examination reveals that the patient has an indirect inguinal hernia. Which nerve is compressed by the herniating structure in the inguinal canal to give the patient pain? So this is supposedly the inguinal canal. Indirect hernia, we all know, enters through the deep inguinal ring. They are saying a patient's having groin pain. See, hernia per se doesn't normally cause pain unless and until it is very big or it is compressing any nerve. Here they are asking that it is compressing a nerve by which there is a groin pain, right? It's a male with an indirect inguinal hernia. Options given here are iliohypogastric, lateral femoral cutaneous, ilioinguinal, and subcostal. So hernia has already started. So hernia has entered through the deep ring. This is, imagine the superficial inguinal ring, and this is what it is, a spermatic cord, which is the main content of inguinal canal in males. Now what happens is, there is one more content in the inguinal canal in males, which is not entering through the DIR, but somewhat distal from the DIS, somewhat between over here, and then it passes down like this. It's a nerve, it's a sensory nerve, that is the ilioinguinal, with the root value of L1. It's a branch of iliohypogastric, and it is actually sensory to the scrotum in males as well as the root of penis. The antipart of scrotum and the root of penis, that is sensory over there. That is how it is reaching through that region of the root of penis and the scrotum. Okay? So this is ilioinguinal nerve. Is it sensory? Yes. Can it cause pain? Yes. L1. So is this dermatome related to the groin region? Yes. Everything is falling in place for ilioinguinal nerve. Hernia history, everything. Yes. Iliohypogastric, it is near, but it is not inside the canal. So chances are obviously less. Lateral femoral cutaneous nerve, that will be slightly laterally close to the ASIS. This causes meningia paresthetica. Subcostal nerve is actually T12. That will be also slightly higher up, and that is not in the canal. So obviously here no option can challenge the authenticity of option C. Therefore C is the best answer over here. Okay, let us see one more. Just a second. Yeah. The 7-year-old admitted to the hospital with severe abdominal pain. Gastroscopy and CT examination reveals a perforating ulcer in the posterior wall of the stomach. Perforating ulcer in the posterior wall of the stomach. Where would peritonitis most likely develop initially? Where would peritonitis most likely develop initially? That's the question. There is a perforating ulcer in the, not the anterior, but the posterior wall. That is the main part of the question. It is in the posterior wall of the stomach. So what is the, where would the ulcer initially innervate, or it will enter into which space? That is the question. Behind the stomach, we all know there is a very, very small space that is known as lesser sac. Is there any option? No. But lesser sac is also known as omental bursa. Omental bursa, another name is lesser sac. The third name of this will be left subhepatic space. Also you can call it as L. This time L is lesser. This is left subhepatic space. Left subhepatic space. Initially, the peritonitis, so we can call it as, will start from here, omental bursa. Then it may from here via epiploic foramen may go to greater sac, may go to hepatorenal pouch of Morrison, depends. Initially they are asking the word initially over here. Answer has to be option number C. Okay. The right subhepatic space is same as the hepatorenal pouch of Morrison. This is Morrison. Okay. I hope you got the point. Let us see one more. A 60-year-old lady had been scheduled for a cholecystectomy. During the operation, the scissors of the surgical resident accidentally entered the tissues immediately posterior to the epiploic foramen. We are just discussing about the epiploic foramen, and here comes the name. The surgical field was filled immediately by profuse bleeding. Which of the following vessels was the most likely source of bleeding? And where exactly posterior to the epiploic foramen some bleeding occurred? What is the likely source of bleeding? For this question, we should know where is the epiploic foramen, right? Where is the epiploic foramen? So if we look over here, again at the esophagus and the stomach, this is some image in the esophagus, lesser sac, the stomach and the duodenum over here, right? Then from here we have this as the lesser omentum, connecting the lesser sac to the liver. And this behind, this position behind the right margin of lesser omentum is the epiploic foramen. this opening behind, I'm again saying behind the lesser omentum, this is behind the right margin of lesser omentum is the epiploic foramen. The resident accidentally severed something behind. So what is the step behind? See, behind is everything is retro. So if you go back to the options, just a second, yeah. Aorta is on to right or left side? It is on the left side, you can rule it out. IVC is to the right side, yes. Is it behind? Yes, could be the answer. Probably looks like the answer. Let us see more options. And yes, IVC is actually the posterior boundary of epiploic foramen. It is the answer. But let us see other options as well. Portal vein, what about it? It is the content of the right margin of lesser omentum. Therefore, it will be anterior to the epiploic foramen. Cut was posterior to the epiploic foramen. Superior mesenteric vein. A superior mesenteric vein actually forms a portal vein below where in front of the third part of duodenum and in front of the uncinate process of pancreas, then it goes behind the neck of pancreas and all that. So is it related to the epiploic foramen? No, there is no relation of it to the epiploic foramen at all. Even aorta is also not related to the epiploic foramen. His answer is option number B. So we should know the what we can say as the relations of the epiploic foramen. So let me just highlight few relations over here. This is the epiploic foramen EP or foramen of Winslow. Anteriorly, what lies is the portal triad. Anterior relation is portal triad. Posterior relation is, we have seen IVC and T12 vertebrae. Why T12, sir? How to remember all of that? All of this, see, transpyloric plane is L1. You see, not transpyloric plane, transpyloric L1, L1, L1. So what is epiploic? Just above the transpyloric. So L1, what is above L1? T12. Right? So anterior, posterior. Superiorly, there is liver. This is probably caudate lobe of liver. Superiorly. What lies inferiorly below? We can very well see. What is this? First part of duodenum. These are the basic relations around the epiploic foramen. Very important topic. Epiploic foramen. Answer is option number B over here. Let us see if you have any other. Yes. 49-year-old admitted to the hospital with a massive hernia that passes through the inguinal triangle. What is inguinal triangle? Hasselbeck's triangle. Which structure is used to distinguish a direct from an indirect hernia? This is basic question. Basic anatomy, basic surgery question. What differentiate the direct from the indirect hernia? Let us quickly look over here. Again, imagine a bigger size DIR, inguinal canal, SIR. This is the midline, so right sided. Here we have a vessel artery running, inferior epigastric artery. From the pubic tubercle, we have a muscle going, that is the rectus abdominis, going away straight over above into the costal cartilages. This is the Hasselbeck's triangle. Hasselbeck's triangle, which gives rise to direct hernia. Indirect, we have seen previous question, comes from here, indirect. This is indirect entry. That is direct entry. What is between them? So is there any structure between them? This is the structure. Inferior epigastric artery. That is a branch of external iliac artery. Also do remember that a small point. Is there any? Yes, there is an option for here. This is the answer. Yeah. Okay, so it's a branch of external iliac artery. Remember that small thing also. Okay. One slightly long question. 21-year-old suffered a knife wound to the epigastric region. At laparoscopy, when the abdomen was opened, it is seen that an injury to the liver occurred. Between where? We can have a look at the question. Between the bed of the gallbladder and the falcium ligament. So between the gallbladder and the falcium ligament, if you are aware of the liver segments, you should by now understand where actually is the injury. Between the bed of gallbladder and the falcium ligament. And the wound is bleeding. Pringles maneuver is performed with a non-traumatic vascular clamp, but blood continues to spurt from the surface of liver. Bleeding is not controlled by the Pringles maneuver. We all should know. We have just seen the lesser omentum, the right margin. If you clamp the right margin of lesser omentum, which carries the portal vein of and hepatic artery, normally the bleeding stops. But here it is not stopping. So you should think what is happening. Which part of the liver? That is this part of the question. And which artery is most likely injured? That is what they're asking. Options over here are, you can very well see, second, yeah, lateral segment of the left lobe and the left hepatic artery, caudate segment of the liver with injury both to the right and left hepatic arteries, anterior segment of the right lobe with injury to the right hepatic artery, and medial segment of the left lobe with injury to the aberrant left hepatic artery. How to proceed with this sort of question? Let us try to understand. Let us all try to understand. See, first of all, they are saying that, okay, this is the liver. Injury happened between the bed of gallbladder and the falciform ligament. So this area is where the injury actually happened. This you should know is which part of the liver. Is it right or left lobe? Remember, nowadays we say it is IVC, this is the dividing line of right and left lobe. So this is which lobe? This is left lobe. Is it a medial or lateral segment? These are the lateral going on the left side. These are probably the medial segments of the left lobe. Is there another name for this lobe? This particular, yes, it is also known as, you guys have guessed it right, if you are guessing quadrate lobe. Segment number 4. Divided into 4A, 4B, that is a different thing. So therefore, injury is technically in the quadrate lobe, or you can say medial part of left lobe. Other point is that they are doing Pringles. They are blocking both the portal vein and hepatic artery. Still there is bleeding from here. It still continues bleeding. How can this occur? It means that there should be something else. What is that? Let us see the options over here. Look at the option number. First of all, confirm the position. Is it lateral of the left lobe? No. It is medial part of the left lobe. Is it caudate segment of the liver? No. Is it anterior segment of the right lobe? No, it is in the left lobe. Option left is only D. Medial segment of the left lobe. This part. Even they can ask you this half part of the answer only. But now look at the other part. With injury to an aberrant left hepatic artery. So that is not a normal left hepatic artery. That is why Pringle's maneuver was unsuccessful. Another artery was coming from somewhere else. Could be some other part of less momentum. Could be the upper part of less momentum. Could be the upper part of less, meaning by see, this is the whole less momentum. Right? Normally we are doing Pringles over here only. Suppose there is aberrant left hepatic artery coming from here. It is not being used, and that is one that is causing the bleeding. You are clamping this only. What about this? The blood is continuously flowing and it is bleeding out. Right? So that could be aberrant left hepatic artery. Option number D would be our best possible answer over here. Right? Okay, one more. 14-year-old admitted to the emergency 2 days after crashing his bicycle. MRI reveals severe edema of the boy's scrotum and abdominal wall and extravasated urine. Which structure is most likely ruptured? Okay, so you can look at the position. It's a 14-year-old boy with a cycle accident, scrotum and abdominal wall, and with extravasated urine. Which part of urethra is it? A spongy, pre-prostatic, prostatic, or urinary bladder? So you have to understand basic anatomy. Are we dealing with the injury to the urethra in the superficial pouch or a deep perineal pouch? First of all, this should be clear. Is it a perineum injury? Yes, because there is involvement of scrotum. Probably perineum. Are we dealing with? We are dealing with a superficial perineal pouch injury. Right? That is below the perineal membrane, where we have the bulbar urethra, the penile, and the spongy urethra. Is there any option like that? Yes, only one option is over here. What about other options? See, pre-prostatic, prostatic bladder, these are all above the perineal membrane. So they are either in the deep pouch. Bladder, in fact, is in the pelvis, not even in the perineum. So bladder is a part of pelvis. Answer is this only. And please do remember, when there is an injury to this part of the urethra, right, then bleeding can go to the scrotum, can go to other abdominal wall, but it won't go to two places. Just remember those two places. It won't go to ischiorectal fossa, and also it won't go to the lower limb. These two places it won't go, though they are very nearby, but they won't go there. So remember, the answer over here would be our spongy urethra. That is where the it occurred. One last question probably. The following statements concerning structure that leave the pelvis are correct except which is wrong over here. Sciatic nerve leaves the pelvis through the greater sciatic foramen. Piriformis muscle leaves the pelvis through greater sciatic. Axoniliac artery passes beneath the inguinal ligament to become the femoral artery. Obturator nerve leaves the pelvis through the lesser sciatic. See, in these sort of questions, it is helpful in preparation because here one statement is wrong, other three are correct. So you are actually gaining a knowledge. Okay. We should know answer over here is option number D, that the obturator nerve leaves the pelvis through the obturator foramen. It is in the, there is obturator canal in the obturator foramen, from where it passes. Rest all these statements are perfectly fine. Piriformis muscle passes through the greater sciatic foramen, with the sciatic nerve, with the superior inferior gluteal vessels, with the nerve to obturator internus, with other small one or two more nerves. The lesser sciatic foramen will basically have those pin structures which were coming from greater sciatic foramen. Then they go into the lesser sciatic foramen, like pudendal nerve, internopudendal vessels, and nerve to obturator internus may go inside the lesser sciatic or may simply supply the muscle. Which muscle? The muscle that fills the lesser sciatic foramen. I repeat again, greater sciatic foramen is actually filled up by this muscle. The lesser sciatic foramen, on the other hand, will be filled by the obturator internus. And remember this. Axoniliac artery, we all know, becomes a femoral artery, right? So therefore, option number D is the wrong statement, hence the answer over here. Right. So that's all, guys. I hope you guys enjoyed the session. Abdomen and a bit of pelvis too. And thank you for your time. And all the best for your exams. Any queries, let me know in our comment box or in our social media handles as well. Bye-bye. All the best.